We've got mountains and mountains of data related to COVID-19. It's hats off to clinicians like yourself and other researchers. You guys have really stepped up and got good data out about this disease. What does your study add to the ongoing discussion related to the care of these patients?
Sure. As I mentioned, what initially piqued my interest as a cardiologist is the cardiovascular manifestations of COVID-19. And that kind of along with a line of evidence that was emerging mainly from autopsy studies where there were suggestions that the endothelial cells or the inner lining of every blood vessel in your body were being either directly or indirectly affected by the COVID-19, the SARS-CoV-2 virus. So, and those were predominantly autopsy studies where on autopsy samples, people were either detecting evidence of viral infection into the endothelial cells, or also in other cases, evidence of endothelial injury or endothelial death in patients who had died from COVID-19 infection. So that was one emerging piece of data that was emerging from patients who had severe cases of COVID-19. And the second aspect was the coagulopathy aspect, that these patients were also much more predisposed to developing blood clots. And between myself and Alfred Lee, who is the other senior author on the manuscript, Alfred is a hematologist at Yale, and he was predominantly interested in the coagulopathy side. Why are these patients developing blood clots? So, and he had generated some initial evidence that there was an elevated level of a protein called von Willebrand factor. It's a protein that can be detected, that you can order with a clinical lab, and it can be detected from the clinical samples. That was significantly elevated in COVID-19 patients we were treating at Yale University Hospital, who were both severely affected, meaning that they were admitted to the intensive care unit, as well as moderately ill from COVID-19, where they were sick enough to be hospitalized, but not necessarily requiring an ICU level of care. The challenge with von Willebrand factor is that it is not fully endothelial specific. It is produced in endothelial cells, but other cell types, including platelets, can make a von Willebrand factor. So, based on that initial observation made by Alfred and our other colleagues from the hematology side, we started to think about ways we can potentially be a little bit more selective in trying to find markers that can detect endothelial injury. There's currently no commercially available test for endothelial injury. So, we put our heads together and try to think about other tests that we can conduct in the research setting. These would be research assays. And we chose a number of markers. And the one that ended up being the most informative was an endothelial protein called thrombomodulin. So thrombomodulin is a protein that is expressed much preferentially in the endothelial cells. It is highly expressed in endothelial cells compared to any other cell type. It is usually on the surface of the endothelial cells. And what can happen in cases of severe illnesses, in other cases prior to COVID-19, is that in cases of patients who have sepsis or significant bacterial infection, or patients who have significant respiratory distress, that this circulating levels of thrombomodulin has been found to be elevated in the past, and it is indirectly a marker of endothelial injury or endothelial activation when the thrombomodulin gets cleaved off from the endothelial cells and can be detected in the circulating blood. So we chose to analyze blood samples from patients with COVID-19 infection, both in the ICU population and in the non-ICU population. And what we found was interesting in that in the ICU population, there was a trend towards the soluble levels of thrombomodulin being elevated. So it was a trend. It wasn't statistically significant overall as a group comparing ICU versus non-ICU population. But when we divided up the patients in the ICU population according to the level of thrombomodulin, and we had a robust enough patient sample that a good number of the patients unfortunately had passed away by the time we completed our study, we found that there was a significant difference in the survival rate among those patients with elevated levels of thrombomodulin versus lower levels of thrombomodulin, where higher level of thrombomodulin had a strong correlation with mortality in our patient cohort.
All right, thank you for that. And now just before we go any further forward, because I know you guys are looking into possibly developing a test or trying to find a new treatment to protect the endothelial layer, is there any limitations or anything that you would like clinicians or people to keep in mind when reading your study to keep away from overinterpretation of the results?
Right, no, absolutely. Yeah. So, I think under the circumstances, we try to test as many blood samples as we could possible. But overall, it is a limited number of patient samples that we were able to test. So I think it would certainly be fantastic to replicate our findings or validate our findings in a larger cohort of patients to make sure that our findings in our number of patients can be replicated in a larger patient population from other institutions. The challenge is that our blood test was collected from each individual at one time point. It would certainly be interesting to see, are there variations are there changes in the level of thrombomodulin that might be more predictive of disease outcome? And these are kind of studies that we have ongoing at the moment. And also from a therapeutic perspective, the question is, is there, I guess a couple of things. One is thrombomodulin, soluble thrombomodulin, really the best marker of endothelial injury or endothelial death? We are considering a number of other markers or other endothelial specific proteins, which may be also elevated in patients who are critically ill from COVID-19 infection. And once we, I think, identify perhaps the best marker or best set of biomarkers that might represent endothelial injury, I think the next question becomes, what can we do about this therapeutically? Certainly, I think, given the prevalence of coagulopathy in these patient population, I think a number of institutions, including Yale, have instituted an anticoagulation algorithm where we treat most of these patients with prophylactic or therapeutic doses of anticoagulation. I think ultimately, if there is a treatment modality that could potentially be aimed at protecting or preserving the endothelial layer, I think that is something else that could be thought about as a potential therapeutic strategy as well.